السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا محمد خاتم الأنبياء والمرسلين. Good morning everyone and thank you for being here. I will take this opportunity to thank Dr. Mohammed Nadar, our acting dean, and particularly also I'd like to thank Dr. Ilham and Dr. Leila for this wonderful conference. We enjoyed great topics from yesterday, and we have the chance to connect with other colleagues in Ministry of Health and also different specialties with Kuwait University. So thank you very much, and I hope you enjoy the rest of the conference. Today I will present for you, actually I will not present for you results, and instead I will present for you protocol of our recent study, which is revolutionizing the rehabilitation for neurological and musculoskeletal disorder harnessing the HAL, which is randomized control trial. In a brief about myself, I got my bachelor from Kuwait University in physical therapy, and then I got my master and PhD from UK, from University of Sheffield. I have many memberships in national and international association, and as Dr. Hisham said, my research interest concentrated in the mental health, elderly health care, as well as the innovative research or innovative technologies, either AI in education or in healthcare. First of all, I would like to introduce the research team, some of them with us here in the hall. So Dr. Muad Al-Haddad, Dr. Muad, he is an assistant professor in our department, and Dr. Munira Al-Qanem, she's a former assistant professor in Kuwait University, as well as Dr. Sultan Al-Silahi from Ministry of Health. And our service provider, which is the supplier for Mycon, supplier of robotic in Kuwait, engineer Dr. Mashal Yaqut. As background, I'd like to start with the statistic. So first of all, we'll go for the global statistics. So the number of people living with the disabilities is rising at an alarming rate globally. So over 1 billion people, which is account for 15 global population, lives with disabilities. And these disabilities leads to significant functional challenges for 110 to 190 million individuals. These motor disabilities reduce the independence and quality of life, leading to higher level of stress and depression. So a holistic approach or holistic rehabilitation is required to address the physiological and the psychological issues. Diabetes, hypertension, the sedentary lifestyle, as well as the obesity. That is developed by Japanese Cyberdyne company. The robotic exoskeletal designed for mobility impairments following the spinal cord injuries, stroke, or different degenerative changes. It's to provide real-time feedback and support via muscle bioelectrical signals. It's to provide also personalized interactive therapy to enhance patients' compliance and participations. It's improve the gait speeds, balance, muscle strength, and daily independence, and target track the patient's performance for tailored therapy plan. Here our research team taking the training, the formal training with the Cyberdyne Japan. Actually, one of the certified Cyberdyne trainer came to Kuwait from Germany to provide this training for us in Adeliya, the Hamid Sagar Center. And we all of us have an extensive training because we are not allowed to operate it without this formal training. So actually we wear it, we feel it, because this will enable us also to apply it for our patients. And we are now certified operator by Cyberdyne. Before I proceed further, I'd like to provide you with some evidence for the effectiveness of the HAL for the either neuromuscular disabilities or musculoskeletal disabilities. So in unit in 2018 studied the effects of HAL on gait coordination and performance in patients with ossification of the posterior longitudinal ligaments post-surgery, and they found significant improvement in the gait speeds, coordination, parameter, particularly in the acute patients. However, they lacked to use the control group, and they didn't specify the follow-up period for the treatment. Tanaka in 2019 studied the effect of high robotic gaits in 11 chronic stroke patients, and they found there is improvement in gait speed, cadence, stride length, and as well there is also limitation in this study, which is lacking of the control group to tell or to compare between the conventional therapy and the HAL therapy. Also, the training fallibility was one of the limitations. Nakajima in 2021 also studied the safety and effectiveness of HAL. So for the rare neuromuscular disease, and they found improvement in the walking cadence strength, and they can conclude that HAL is safe, effective, and can become a potential standard treatment. A systematic review and meta-analysis conducted in 2022 with a scope of 9 studies and 230 patients just compared the robotic treatment or rehabilitation with the conventional methods for those patients post-surgery with total knee replacement or total hip replacement. And they found that there is improvement in the outcome demonstrated in the reduced pain and increased gait speed. There was, however, a need for a greater or larger high quality studies. So the existing literatures indicate that HAL is effective for neuromuscular and musculoskeletal disorders or disabilities. However, there is methodological limitations affecting the generalization. Therefore, we aim in our study to assess the impact of HAL training on the function, cognitive and the quality of life aspect in people with neuromuscular and musculoskeletal disabilities. So we hypothesize that those who are receiving, the patients with neuromuscular disabilities or patients with musculoskeletal disabilities who receive the robotic or HAL robotic treatment together with the conventional therapy will demonstrate greater outcomes or better outcomes measures compared to those who receive only the conventional therapy. Alternatively, also we hypothesize that those who receive the HAL with the conventional therapy will have similar outcome measures scores. As a method, as I said, our study is randomized control trials with pre and post measurement design. The setting for this study, inshallah, will be the physical therapy department at Kuwait hospitals. And our inclusion and exclusion criteria stated here for you guys. It's actually, we will include those with a stroke, with neurological dysfunction, osteoarthritis at wrist, knee, ankle, or low back. And we will include those both gender, male and female, Kuwaiti, non-Kuwaiti, above 18 years old. And we will exclude those with difficulty to wearing the HAL due to deformity or due to contracture. Our sample size calculated based on the G-power calculation, so the total participants will be 60 and 15 participants per group, as we will have 4 groups, 2 control groups, one for neuromuscular and one for musculoskeletal, and then we have experimental group, 2 experimental group, one for neuromuscular and one for musculoskeletal patients. We will to recruit the patients, we will distribute announcement at all hospital sites, and those who are interested will contact the researcher. We got an approval from Kuwait University, a condition with the Ministry of Health approval. Actually, we are awaiting the Ministry of Health approval to embark our study. So as I said, we will assign, this is just the measurement, pre and post measurement. So we will take the measurement before the treatment, and then both the intervention over the period of 12 weeks, which is tailored to individual needs. So the patients will be, or the participants will be randomly assigned to one of these 4 groups that I just explained it for you. And as an outcome measures, the instrumentation that we will use, we use 6 measurements here in this study, starting with the time up and go to evaluate the mobility, balance, and fall risk. We will also assess the walking speed using a 10-meter walk test, and we will assess the static and the dynamic balance using the Berg balance scale. Also, we will use the functional independence measures to assess the functional independence in self-care, mobility, communication. And also we will take measurement for the patients using SF36 to assess the quality of life and health status. And we will check also the level of depression, stress, and the patient using DAS-21. As a statistical analysis, we are aiming to use the SPSS 29 version, and repeated measure ANOVA will be applied, and the p-value will be below or equal to 0.05, considered significant. Okay, I will show you some videos or some cases about our training, the research team, while we have our extensive training. This is one of the patients. During our training, actually, we receive real patients in Hamid al-Sagr Center, spinal cord injury after traffic road accident, stroke patients, osteoarthritis patients, and this case was treated by me, which she is 58 years old, female patients present for us with osteoarthritis. She has pain in knee and difficulty in praying and walking. And I use for her the hull because we have single joints, and we have, I will show you in a bit, and we have the hull for the lower limb, the hyper. So this video, I was training her. She is wearing the hull. As I show you in the beginning, we all wear it. To be honest, it's heavy, okay? So this is why in our study we aim to provide the treatment 2 days a week. 2 days a week, so to allow them to rest because it's heavy. Okay, here I'm wearing the hull during our training. So I was walking with the hull. Okay, if you see in my back, this is the control system of the hull. Okay, there is machine behind. This is where we change the mood, we increase or decrease the assistance that we provided for the patients to train them. Excuse me. Okay, this is the single limb. Okay, so here they apply it for me just for the knee, and this is also I use it for my osteoarthritis patients. I use for her the hull, and some session I use for her the single limb. And it gives good feedback, good improvement for the patients within 1 week. Every day we have the patients for 1 hour per session, and she reports really good outcomes or feedback. At the end, I would like to acknowledge Kuwait University for their invaluable support through the research sector, as well as the Kuwait Foundation for Advancement of the Science, KFAS, for their generous funding of our research. I'm excited to show you these pictures, and we are with Dr. Amina Al-Farhan, the director of KFAS. We really grateful for her belief in our research and inviting us to discuss it more. So we was really grateful for her support. Also, I'd like to thank the MICO, which is the service provider, the supplier of robotic in Kuwait, and the Cyberdyne Japan for their collaboration and expertise in health robotic technology. Thank you very much for listening.
Thank you very much for taking from those, please. I would like to open to start with having a question from the audience. If there is any question with any of the presenter. Question? Sorry.
Virtual reality, because we use it in our schools. Actually, it has lots of advantage, like there's immersion for the patients, and there is anticipation, there's interaction, and also you can control the difficulty. So you can put new challenge, and you can make it either difficult or easy. But maybe this things that we touch it in our patients for especially the wheelchair. So with the wheelchair, he finds himself walking. It has very good impact and positive impact on him, as feeling that he's really walking, even if he's on the wheelchair.
Definitely.
So this is my
VR is wonderful. I loved VR since I was a kid, and playing and immersing myself in the reality that VR gives me was wonderful. And seeing right now with the literature and with how everyone is using it, it's really nice to give this to our patients, to allow them to imagine, because in the end, imagery is one of the main contributors to rehab. If I can imagine the activity, I'll be more motivated and I'll do it. So I completely agree with everything you said.
Safe, he will not face any danger when he uses that.
Exactly. It's safe and it's easy and it's everywhere. Like even rehab, there are other apps we can use, but inshallah soon, rehab will be more advanced, and I hope I can show it to you one day.
Yeah. And about the I love the robotics in the hand, and actually the advantage that the patient itself is doing it voluntary, as voluntary. And afterward, with the positive and progress, he will be able to do the movement without the robotic. Is that right?
Yes, you are correct. Actually, if I just input in your questions or your comments, actually we aim for, first of all, to avoid the long waiting list and the delay in the rehabilitation. We start immediately, we hope to start immediately with the HAL, with the patients, because it's reduce the recovery time, and it's detect the reserve signals within the muscles, and from that we will train the patient. Okay, and the effort of the therapist should provide close monitoring for those patients. Okay, but still the effort of the physiotherapist is less than when it's only with the therapist. So the machine or the system itself, we will do the movement according to the detected signal and the repetitive of the exercise. So it is less effort for the physiotherapist. I'm sure we have many of you treated stroke patients, and doing the passive range of motion for the patient to preserve the signals. It's heavy for us because of the spasticity sometimes or the tonicity of the muscles. So we just give monitoring, and the system will do the exercise, the repetitive exercise.
Thank you so much.
Any more questions? Any more questions?
Yes, I have a question for Dr. Najla. I found the research very interesting and impressive. I'm just wondering about the elastosonography, or is it sonoelastography? Is it possible for a physiotherapist to administer this, or do we need to depend on somebody from? Can we administer the elastosonography or the sonoelastography?
Very sensitive question. So, administering the sonoelastography for my PhD, it was part of my education in terms of sonoelastography and ultrasonography. For research purposes, yes, you can, because I took the approval from the ethics committee, and I have Professor Akram Spati with me in the team, but I administered the measurements. But we are talking in a conference called Next Generation Health. So we already completed our role as researchers, and we have established the value of the system and how we got trained, the track, an example of how it has enhanced our knowledge in one of the complex musculoskeletal conditions. Now I think it's the role of the administrators and stakeholders to adapt the system, because Next Generation Health has two parts: the part from the clinicians, the academics and the researchers, and the second and the most important part comes from the stakeholders to take the ideas, the work, and implement it into policy changes.
I also have a question for Noor. It's very exciting, the use of VR. I'm just wondering about the accessibility. So will this be, because you mentioned there's an application, so for the, let's say the VR headset, will that also be accessible?
Yes, so the VR headset, you can find it on X-Head, and it's easy to find. But basically, you download the mainframe, let's say, or the screen on your iOS or Android, and then in the VR headset, you'll just download Rehab, and it's going to be connected. So whatever you use is going to be available in the headset.
That's really, really easy.
Thank you.
And Dr. Latif, I also have a question for you.
Yes, sure.
I'm also wondering about the, can you remind me of the name of it?
How?
So is that only available in the clinic, or can patients possibly use it at home as well?
Yes, actually also the same things here. This is like the long-term outcome of our research. If our research found that it is effective for those kind of patients, then the next step is to establish a protocol within the Ministry of Health for the therapist want to use it and want to not to use it for the patients. This is the first thing. And at this time, actually, it's need a policy to be established within the Ministry of Health. Actually, as you said, we got formal training to, even in Japan, they not allow you to operate it without extensive training. So this is also from one of the challenges in the future. We would like to establish it as a combination with conventional therapy and physiotherapy for treatment for patients with neuromuscular musculoskeletal disorder. The cost of this new technology, so it is a little bit expensive. We need extensive training for the therapists before they use it, and I think the maintenance and the technical issues within because it needs to be consistent maintenance and technical support. So hopefully in the future, inshallah, depending on the evidence, we hope to contribute to the body of the evidence for using this advanced technology, and also for, inshallah, exploring the new advanced technology to support the rehabilitation or physical therapy rehabilitation.
Thank you.
More questions?
Thank you all for these informative presentations. My question is for you, Dr. Najib. Regarding the elastosonography,
do that, and we have proven that in our, I call it JMAT, which is gastrocnemius Achilles tendon complex. It is sensitive to detect differences between people with connective tissue disorders and high mobility. But my advice, you are going to explore different musculoskeletal conditions to establish their ability first.
One last follow-up question. You mentioned that the device itself has its own calibration where it tells
Yes,
you.
on the screen, yes.
Is that available in all models? or
Yes,
is it
yes,
specific?
yes, all the models. Yes.
Any more questions? If there is no more question, I will conclude this session. I would like to thank our participant, Dr. Najla Sirri, Noura Fadli, and Dr. Nadif for this wonderful presentation. And thank you very much. And now we move on. Right.
Thank you, Dr. Hisham. Thank you for the lovely session. Now I would like to ask Dr. Ilham Dosiri, رئيس اللجنة المنظمة، دكتورة ليلى الغنفر، رئيس اللجنة العلمية, to give the awards for the participants. Okay, Dr. Hisham Mawli, please. ممكن صوت غير واحد دكتور هشام. حياك الله دكتور. حبيبي يسلمك هذا دكتور. دكتور الطفل العزيز.
ما شيكت انا يطلع دعايات
حلو.
كذي. ايه لانه حرام حلو، ممكن يخلص سلايد وما خلص الفيديو، حرام. ايه فخلاص. في بعد السوفت وير لا خليته ما سويت له قص، لان السوفت وير كامل هو الفيديو حلو، اللي هو الاناليسيس. بس دلوقتي الدكتور
الصورة اي اللي يحرك
ايه ما قصيته لانه هو حلو الفيديو.
هو قصير اصلا.
ايوه
20 ثانية.
سوي. اوكي
وينه؟
وين ما شفته.
هذا فيه. لا
اوكي بلاي باك اوتوماتيك لوب يمكن ما طلعت ولا
لا الظاهر يمكن بسرعة طول.
ايه بس كذي. ايه اول واحد يسوي بس اشيك. السكند قاعدة اعطيهم انا.
How sure?
ايه هذا من
لا وايد صغير يمكن. لا خلنا
سمعنا هذا. انا انا اصلا ابي السماعه.
انت تبي سماعه؟ وين السماعه؟ على الفلاح؟ شو خلينا نحط واحد احتياطي اذا هذا خلص بطارية. احطها هني. لا ما
سكت.
ايه صح ما تعرف. عادي عادي اذا قالت على الخشب صح. اقول لك إيه، انت عندك
طفي الميكروفون لحظة. Not working. أيوة. يلا السلام عليكم جميعا. Shall we start please? Shall we start? Can we start? اشتغل.
بسم الله الرحمن الرحيم. الحمد لله رب العالمين. جميعا السلام عليكم ورحمة الله وبركاته. نحيي جميع أعضاء والمشاركين وأبنائنا وبناتنا الطلبة. Physical therapist who provided earlier, and inshallah we hope all of you inshallah will be there. Physical therapy session. Inshallah we will start by presentation provided by Dr. Mohammed Al-Shihab. Dr. Mohammed Al-Shihab, he is he finished all his bachelor, master, and PhD from England. Inshallah, you will. The title of the presentation is Utilizing Technology.
Inshallah, اليوم it's a reflection of how technology, and when we have advancements in technology, it changes our in understanding medical phenomena, and this is specifically talking about spasticity. And I know a lot of you here are my students from second and third year who have some type of some of the content of this presentation before, but not in the depth that we're going to today. Special thanks to Professor Anna. It goes back. Special thanks to my Professor Anna work along with which is a Western and Northern European team that developed this methodology about 15 years of research, and he's currently in the executive dean at Government University. So let's start with what is spasticity. It is usually caused to what we call the central nervous system. And that lesion related to a medical condition that is cortical sometimes, such as strokes and MS, or it could be related to the spinal cord, such as spinal cord injuries. And it is what is called, it's part of what is called an upper motor neuron syndrome. And this upper motor syndrome is characterized by, some of them are called positive, others are called negative. And when we say positive features, we mean that related to the activities that hinder or stop the central nervous system to be controlled, such as primitive reflexes. And when we call it negative features, which means that the overall control of the central nervous system to produce that motor control is affected. That is why, and spasticity falls under the positive features of the upper motor neuron. That is why the reflexes in kids with spinal cord injury, which is an injury to the central nervous system within the first 2 to 3 years of their lives. So, as also, we could say that someone is or hyperreflexic, which means that their reflex exaggerated, or primitive reflexes do still exist. They haven't developed correctly. That my professor used to hate, because muscle tone. And that muscle tone, how do we define muscle tone? What they found out is when clinicians say increase muscle tones, there are two main features. Either the muscle is ready to act, which means it is excited at a smaller threshold, kind of resistance when you, I hope I don't mess this up, perturbation, when you introduce perturbation, or that one, and that's what we call muscle tone. So then Lance's velocity dependent increase in tonic stretch reflexes, and then reflex, which means our central nervous system is something else, hyperexcitability. The method that we measure spasticity, that you see it, and our students will be seeing it in clinic, as you can see on the left, and we move it to, so we check the motion and we make sure that the patient is, then we move the limb in velocities. Once in a slow velocity, the second one is in a high velocity. Then we grade that feeling that we clinically, and we are trained to grade. However, the latest research is showing that the modified Ashworth scale, or even further, the modified Ashworth scale, is having inter-rater reliability because of its nature. The other type of method that we use to measure spasticity is our clinical, it shouldn't say clinical scales, it should say clinical features. We observe tests. We do tests that we see, don't see in typically developing people or people with no brain injuries. And the one of them. Obviously, there are other spasticity. This is only one of them. And you can see this is the normal reaction that you would expect when you move the rod around the foot. And this is the Babinski sign. You see the extensors getting excited. The third method is the biomechanical method. And one example of those, because there are plenty of those, is the Wartenberg pendulum test. What that means is we let the limb freely fall, and they swing, and we try and grade this or describe this motion. So spasticity definition, back to it. The modified part of it is characterized by velocity dependent, which means when you go faster, it's higher, and it is a hyperexcitability stretch. Happens because the muscles is coming to the muscle to switch it off is not working correctly. So it is hyperexcitable. Any connection to the muscle will excite it, making it contract, and you feel that resistance. So when I was growing up, I was good in math, and everyone was thinking that I would be an engineer someday because I was good in math. However, I went into occupational therapy, and I want to deal with people. However, when I went on and did my studies, I like quantitative data, and this is what led me back to a team full of engineers and mechanical engineers and coders and all that to produce these kind of data. So when we say the spasticity is velocity dependent, what we mean is what the implication that velocity dependency is only exclusive to spasticity. Otherwise, we're going to confuse it with other phenomena that happen in the human body. So a study was done by DeWolf, and what they found out, they did, you can see the elbow angle, which shows you the speed of the motion, and you can see the total when you move it. As you increase the speed of motion between A, B, and D, you see the resistance and the torque increases, even though this person is normal and their muscle is switched off, which means does not necessarily it could come from what we call viscoelastic tissue of the muscle itself could produce this velocity dependency. The other assumption, or the most common definition of spasticity, was that you would always lead to an increase in resistance. What that means is, when I move it, this is always the byproduct of the increased muscle activation. However, these patients, botulinum toxin A, 4 weeks after they've given the botulinum toxin, the measurement of stiffness was conducted. And you can see the force is on your y-axis and the angle on x-axis. And as the motion, this is the, you can tell by the duration. So before we sloped the stiffness against change in angle. And you pre-botulinum toxin, or to use the commercial name, Botox, did not have any effect because dampens muscle activity is not always related to the increased resistance. So that's assumption number 2. So it's related to muscle. It's not always relative to. So what is it? This is the work of an engineer. So we said passive movement. Engineering point of view, to them, we need to measure the, because the modified Ashworth scale, a limitation of how much force, it's different if applying it to a male therapist who's applying it. How can you standardize this? So the engineers in the team said, we need to look at the force. And this is the transducers that measures how much pressure apply to the limb during your spasticity test. So keep an eye on the colors. They're gonna make sense later. So force is in red. The next aspect is angle. We need to know the angle. These are called electrogoniometers. You put them on the proximal and distal segment, and as you move, well, after calibration, of course, as you move, it measures how much angle you're doing in your joint. And from that, we can deduce velocity. Because we know the angle, we're measuring it in real time, easily detect or deduce the velocity that the limb is moving in. So if we're moving the limb slowly, we would know. If we're moving the limb faster, we would know because we are measuring change in angle. The last bit, I know it's slightly confusing. Keep an eye on the two colors because they're going to make sense later. We're measuring, or myography, sorry. What that is, it measures muscle activity during the test. So it's it has electrodes, and you place them on top of the, and it's supposed to give you activity. So everything together. I'm sorry about the quality of the picture. I couldn't find anything better. Putting them everything while you're doing the test. You have your EMG, you have your angle, and you have your force. So now we're talking about measuring quantitative data to produce when we talk about spasticity is the existence of resistance, but it should also be related to muscle activity. That's the software that we come up with. Every single parameter that we're measuring will come as a graph. Are EMG ones, the electromyography. And the way it is done, measuring the forces, we can quantify resistance. We're measuring changes in angle, which is gonna give us more information, resistance angle, at which point the resistance kicked in, the velocity movement, and the acceleration, deceleration. And that is very important later on to measure jerkiness, because jerkiness is the change in acceleration and deceleration. And finally, the electromyography can give us the amplitude, how much electricity our muscle is producing, and the frequency, how quickly it is producing it. So in that case, it tells us if the muscle activation is happening at a certain angle, the patterns, at which angle the patterns of the muscle activation and deactivation. So putting them all together with the colors, the red, the blue, and the two EMG ones, we can see in the red graph to the left side is the slow motion, and the fast one on the right, and you can tell by the on the x-axis. So the first one, when we did measure spasticity, we classified 4 different groups. The first one was velocity dependency. What that means is you barely see any flexors, because it is done to the elbow joint. You barely see any flexor muscle activity during the slow motion, where in the fast motion, you see a spike in the flexors. And that tells us that during the slow testing conditions, we did not excite the muscle. However, when we did the fast, the muscle was activated, and that's why it's called velocity dependent. The second type is the position dependent. As long as you're moving it and going through the motion, whether it's quickly, whether it's fast, the muscle activates and it keeps on activating. That is why it's called position dependent, because it's independent of the velocity. In both, you are exciting a muscle that should be silent. The third type is just a combination of the two. These type of patients, they could have velocity dependency and they could have position dependency. The last one, last night phenomena, which I love, because it is very clear. As you're moving the limb, whether it's slow or fast, you can feel the resistance by looking at the force in red. In red, you can see the resistance up because you're applying more force, and the flexors are very excitable, and all of a sudden, they crash in both conditions, fast conditions and slow conditions. And that's why Swiss Army, you know how you move it, and toward the end just snaps in? Night phenomenon. So that's the fourth type of spasticity when we measure it objectively. Finally, is the muscle is active all the time, and it's a phenomenon that we call Tachycardia. So this quantitative data have us change our perspective of this. Now we need to redefine it, because the velocity dependency aspect of it that was mentioned in the previous definition, and we had to come up with something. And some people might say that this is to its broad abilities, too broad. But at the end of the day, this definition was driven by the data, not the other way around. Ordered in sensory motor control resulting from an upper motor lesion presenting as either an intermitting or sustained involuntary muscle activation. And that's it that came out of it. It's still not being implemented, even though it's been more than 12 years since this classification came out. And in the future, it will be adopted somehow. Obviously, it has its own limitations because it requires a motion capture system that is relative to convergence currently, but they still run at around maybe 7,000 kD. The procedure is relatively lengthy to administer, especially with children, and you wouldn't expect them to be, not all of them to be able to tolerate it. EMG alone, when we measure EMG and we see the muscle activates, it does not represent intent. What that means, it is limited to the patient's adherence, because it could be confounded by patients actually activating the muscle voluntarily. So we only have to assume that the muscle is, that this patient is able to adhere to the instructions that we're giving to him. These are the resources, and thank you for listening.
So we can Dr. Mohammed for the excellent presentation, and your efforts are appreciated, Dr. Mohammed. Therapy department in the Ministry of Health. She is a graduate from the University. She was admitted in the first batch of OT in Kuwait, and also, luckily, she is now in the first batch of our master. So, inshallah, will provide you with a presentation entitled Driving Assessment, Understanding Limitation in Human
Okay, hello everybody. My name is Bashar Kenderi. I'm from Ministry of Health. I'll talk to you about driving assessment in order to understand the limitation in human functioning. First, we need to understand what is occupational therapy. It's a healthcare profession concerned with promoting health and wellness by enabling people to participate in everyday activities. Driving is an important instrumental activity of daily living that is important for maintaining independence, feeling of self-worth, being connected to life and community. The driver rehabilitation is a specialized area in occupational therapy that help individuals regain independence in driving after experiencing an acute or traumatic injury, illness, or disability. Occupational therapy practitioners provide a critical and essential combination of skills and abilities to support individual driving and community mobility in order to maintain their engagement in community activity, which will eventually improve the quality of their life. What are the medical conditions that affect the person's ability to drive safely? One of them is the advanced age, the visual impairment, the amputation, the TBI, the spinal cord injury, MS, Parkinson's disease, CP, Alzheimer's disease, mental illnesses such as anxiety and depression, ASD, ADHD, intellectual and learning disabilities. So our services will be that we're gonna evaluate the client, we're gonna assess them, then we're gonna apply some intervention in order to either remediate or compensate for the lost skills. We will do a comprehensive assessment of cognitive and perceptual skills, sensory function, motor and coordination function. Then we're gonna conduct behind the wheel or by using the driver simulator in order to evaluate the client's ability to drive safely. The driver specialist can apply different interventions to improve the physical, sensory, cognitive, and perceptual skills needed for safe driving in order to maximize the client function and gain the skills to build or regain the driving independence. Then the driver specialist can conduct on-the-road training to enhance the client's ability to drive safely. Then the driver can prescribe the vehicle modification that the client needs in order for him to safely drive the car in case that he cannot drive normally like any other people. Then he can also identify alternative transportation method for the client if the driving safely is no longer possible for this particular client. So we classify the client into 3 categories, either gonna be in the green one, which is safely for them to drive, or they're gonna be in the yellow, which they intervention, so that we can determine whether they will be in green or in the red one. The red one is that they are no longer safely can drive the car by themselves. So in the red one, we have to find alternatives for them to drive safely. Okay, in our occupational therapy, we have something called the practice framework. We will consider several things, such as the client factor, performance skills, performance pattern, the context and environment, and the client occupation. So, in the assessment, what we will do, we first will consider the performance pattern, which is what is the habit of the client, what is his routine, what is his role, why he needs to drive the car. Then we're gonna assess his performance. We'll see his motor skills, such as how he gonna stabilize himself inside, how he will reach for the equipment that's needed to drive the car, how he can manipulate the key, how he can coordinate and walk to the car to get in and out of it. Then we will consider the process skills, how he will attend tasks, how he will use the car object correctly, what is the initiated driving activity, how he will start, and so on. Then we will look at the client factor, his values, beliefs, and spirituality. Most of the clients, they do believe that they have the right to drive the car as the normal people. So we need to make sure that they can reach this level. Then we're gonna assess their body function, such as the mental function. We will assess the main cognitive skills involved in driving. Then we're going to assess the sensory function. We will assess the visual, the touch, the proprioception, hearing and listening function, vestibular pain, because all that involved in driving. Then we're going to assess the neuromusculoskeletal movement, such as of the joint and the bone, the muscle function, the movement function. Then we will see the context and environment factor behind the wheel or using the driver simulator, as you can see from the picture. How he can get in and out of the car, how he will adjust the mirror, how he will step on the accelerator brake, and how he will move the steering wheel. Intervention, we're gonna improve all those factors, the performance skills, the performance pattern need for safely driving. And then we're gonna conduct on-the-road training to enhance driving safely. Then we're gonna prescribe, in case they need some assistance, we're gonna prescribe the vehicle modification that they need to drive safely. As you can see from those pictures, we have different things that we can prescribe for them. You will see different type of modification. This one, the ones below, is called the chest strap. Stabilize himself so that he will able to reach for the steering wheel without leaning forward. Then if driving is no longer safe for this patient, we have to identify alternative transportation method for him in order to avoid harming oneself and society. That's it. Thank you for listening.
Our Dr. Hamid Al-Hamid, he is an assistant in therapy. He got his bachelor's degree from university. He was a presentation, the role of assistive technology in occupational therapy. Welcome, Dr. Hamid.
Hello, everybody. I'm honored here to present in front of my previous professors and my colleagues, and I can see plenty of students, OT students and 40. So I hope that most of you remain till the end of the day. I know some of you are exhausted from yesterday, but I hope you give the chance for the third session and the conclusion of the conference. So thank you for attending. As occupational therapy is a holistic approach, there are different branches, neuro, beads, driving rehab, and today I'm talking about assistive technology. And this may be familiar, some of you are familiar with different type of assistive technology, but I'll talk about the role of occupational therapy with assistive technology. At the end, I'll talk about the new trend here in the world about AI. How can we as occupational therapists use AI in our practice? Assistive technology is a broad term. It is a wide range of equipment, devices, and systems. Closer? Okay. It's related to daily living activities, to mobility, to communication, to education, and employment. The main definition of assistive technology is any be used and any product prescribed by occupational therapist, or you can buy it from any shelf, or anything that you can obtain to help you to be independent, and it's especially used with people with disabilities. So assistive technology can be used in different areas. For example, for people to use it in their daily living activity like home modification, AAC for people with speech problem like autism, any accessory, any disabled people who can have limitation, vision problem, hearing problem, couldn't use the computer, so we can provide different type of assistive technology like adaptive keyboard, ergonomic chairs that help people to be independent while using the computer, driving and transportation like Ms. Bashir Kendiri mentioned in her nice presentation, environment modification, learning and cognition, orthotic and prosthetic. So there are a wide range of different categories of assistive technology we can use with our client. Our main role as OTs, we can evaluate the level of disability of the client. We can evaluate the level of cognition, sensory problem, motor problem. So we are trying to fit the device to the person, not the other way around. So we need to customize the device so the client can use it independently. Also, we can select the device. It doesn't need to be expensive to be useful for our clients, so we can find something within budget so everybody can afford and have access to these devices, okay? Also, as OTs, we have a role in training our clients and the caregiver how to use this assistive device. So assistive device, there are different and wide range of assistive device. It is not necessary to be electronic, so anything you can use in your daily life could be assistive device, like the glasses, the wheelchair, adaptive pen, adaptive keyboard. You need to be creative to know what is considered as assistive device, okay? So, first of all, we need to assess the daily needs of our clients. So we shouldn't prescribe everything. We need to know what is the client factor, what is meaningful, what is purposeful for our client, so we can help them be independent and participate in social life activity, in their work, in their education. So we need to take the history of our client, what the level of cognition. For example, geriatric, older people, we cannot prescribe certain thing for them, so we need to find something age appropriate, the language barrier, the sensory issue, and motor issues. There are different levels of assistive technology starting from no tech to low tech, medium tech, and high tech, depend on the need of our client. For example, as OT, we have a role in designing specialized seating system for our client, for people who sit on the wheelchair or sitting on a chair for a long period of time. They can develop something called ulcer, bed ulcer, so we can assess the pressure source and pressure management to have a comfortable life. They can sit for a long time without causing any side effects. So we are trying to maximize the ability of our client to use upper extremity, so we shouldn't design something for everybody as a universal design. We need to customize what is there to the need of our client. There are different types of wheelchair. There is the standard type of wheelchair. There is ultra light wheelchair. There is powered wheelchair. Unfortunately, most of our clients here in Kuwait in the Ministry of Health, they want to go for the powered wheelchair. They think this is powered, this is electronic, this must be good for us. And if we are trying to convince our client that you don't need the powered wheelchair, they say you are not paying from your money, your own bucket. So we are facing some difficulty to explaining the need. Sometimes the ultra wheelchair will help the client to go to different places to use their upper limb, because if you don't use it, you will lose it. So we are trying to help our client to use their potential capacity and strength. As I mentioned, there is adaptive computer, different pointer, different keyboard. So with technology, we can find different way, and we need to educate our client what is available in the market and how to use this efficiently. There is some tools that help, like optical character recognition, text-to-speech for people who cannot read. There are different keyboard, different mouse, so we need to find the good type. As you know, in the academia, you are using computer for a long time, writing research, doing presentation, and sitting for a long time, especially for people in their master and PhD, spending hours and hours daily writing their thesis or dissertation. So using the keyboard for a long time might cause carpal tunnel. So we are trying to provide some specified keyboard for people who use the computer for a long time. There are some electronic devices for daily living, some telephones. So all these technology, there are some applications, some softwares, some apps that help people to use it. For example, people with dementia, there are some reminders, some apps that help them to use their, for example, people with Alzheimer might get lost, so using some Google Maps, some translators, some reminders, some software that help them in their needs. There are some communication devices that could be used, some board for people with speech problem. The main barrier that occupational therapy face while using the assistive technology, that some patients have some unrealistic expectations. Some devices are break down, and it's difficult to maintain these devices here in Kuwait. So we need to find the best brand, the best tools that could be last for a long time. And sometimes some tools are expensive, some wheelchairs are expensive. So especially if you are prescribing a wheelchair for a child, with time they are growing and they are becoming bigger and taller. So instead of prescribing a new wheelchair every while and then, adjustable for the needs of our clients. So with time we can change the measurements so it's fit the client for a longer period of time. For example, there are some environmental factors. Even if we prescribe some wheelchair, a nice wheelchair that fit the need of our client, but sometimes accessibility problem. The physical environment are not suitable for our clients. The door width, there are no ramps, so it's difficult for our client and for people in general to move around. Now regarding AI. As you know, now it is the trend and everybody is talking about the AI, and there are plenty of research talking about the use of artificial intelligence in our practice. There are debates. Some people are with using AI and some people are against it. And I'll mention the role of AI in our field and the barriers and some concern regarding using AI as student and as practitioner in your education or in your work. It's important to have an open mind about using AI. People can use AI in assessment and monitoring. So we can use some devices that the client can wear to measure the heartbeat, especially for people with chronic condition. So to manage and monitor the progress they are keeping throughout their day. So AI can help assist occupational therapists to have a better clinical judgment, help them with their intervention plan. So it's help us with the assessment and evaluation and create a suitable plan. We can use virtual reality. We can mimic the real life for people, for example, with PTSD, for people with burn. So we can mimic the reality, so we help our client to train in the clinic before going into practice. And in education, we can use, I saw some universities are applying the simulation for their client. Instead of putting their students in the reality, in the field work, they can have some simulation in the university, trying to help the client to practice and to be confident before going to real practice. But are there some concerns? It's always better to have practice in the real place, but sometimes using simulation is a good idea. Regarding administrative tasks, some university and some hospital are allowing the OT to use, for example, ChatGPT in their practice as assistant in writing and putting notes and the evaluation process, and putting educational handout, doing checklists. So it's make the life much easier. Okay. There are some apps, technology that can be used by the clients to help them in their practice. And there's some studies found that using AI by the practitioner help the OT to minimize the burnout among the OT and different rehabilitation team members. And also aging in place. As you know, the smart homes. So we can use smart home for our client. They can use, for example, Amazon, Echo, Google Home. This is useful. I know might not be accessible for everybody because of its cost, but it could be used for people at their home, especially for people with fall prevention. It is measuring the movement of for the client. There are some sensors in the home. If the client is not moving for a long period of time, it might detect and send an alarm. Ambulance can come to the home to help, so it might be beneficial functionally, psychologically, and socially with our client. My final slide, the AI concerns. There are more concerns than this, but these are the main concerns. The issue of client privacy. As you know, using ChatGPT or AI, the information are in the cloud, so it might be the privacy of our client might be in danger, because once it's there, it is there, and this is a big issue. Some clients will not accept you to put their data or information in AI to generate an intervention plan. There are some potential bias in AI algorithm. As you know that AI is trained by the human, so sometimes it is fake referencing and fake data, and it might be biased. So it might create inaccurate and misleading information. So you need to be careful. You need to double check everything you do before putting and submitting. For example, my advice for the students, some of you might use AI in their assignment, and they are posting and submitting the assignment, reviewing the assignment. So there is a risk of over-reliant on the AI. So use it wisely, use it with cautious, and it is a tool, and it's still improving and growing with time. So please, this is the trend of AI, this is the future, so keep an eye on what is going in this field. Thank you for your time, and thanks for listening.
No, this is multiple research over 15 years that were developed. For example, they started with just biomechanical measurement, then they added EMG, and so on and so forth. I just applied this to the graphs that you saw in my research.
Are these now the gold standards? Are these the standards in how to diagnose spasticity? The previous definition is not different than the new one, and the new one is the previous one.
Yes, in the United Kingdom, the NICE guideline, the National Clinical for adopted the definition. However, in practice, it's still not being developed. That's why there is like a team of advocates. Very difficult to implement for every single patient in a neuro unit that is already busy. The procedure to set up takes about 20 minutes. then you need to calibrate all the machinery, then you do your assessments. So that's why it is not being implemented, because there are other considerations that go beyond the clinical applications of it.
Thank you, Mohammed.
Thanks, Dr. Zena, for excellent talks. My question to Ms. Bashari is these techniques for driving license literally correlating with what your role? Are you connected to traffic?
Ministry of Interior, yes. We receive the referral from them, and then according to our recommendation, we will see whether this client he fit to drive safely or he need a special license driver with the car modification. And this is what's going to be written in his license.
Thank you.
Thanks for the questions. I think as our team, we need to aware of different kinds of technologies, and we need to educate ourselves what is new in the market, because as I mentioned in my lecture, that there are some expensive tools, and if it's expensive, it's not necessarily it is the ideal fit for our client. So we need to find the ideal solutions, and there are plenty of barriers. Some of them are outside of our available in Kuwait. It is emerging year by year, so we need to keep our eye on what is different and what is new. Good. Did I answer my question? Or questions correctly?
Yes.
It's depend on what is the impairment that he's had. And cognitive is considered one of the main things. It's number one priority in driving. If he has any issue, then we immediately gonna reject him. He is not fit to drive. If it is mild, then it's okay. He can fit to drive, but not necessarily that he will need some modification on the car. And he does it for his skills. You're welcome.
Thank you for your question. Any other question, please?
Hello, my name is Hanadi Hussein from Ministry of Health. I'm a health informationist. I would like to ask you about, don't you think that in the era or the time of AI, we need more regulations and laws to regulate the use of AI, especially in the health sector? Thank you.
I totally agree with you. AI is growing and people are using it daily, but we need to have AI regulations, even in here in Kuwait University and the Ministry of Health and in Kuwait in general, because some people are using it in crime and so on. So I agree with you. We need to sit together with standardized rules and guidelines of how to use AI in the right way.
For us, we are working with Ministry of Social Affairs. We're prescribing now for them the wheelchairs, but we are working also in providing the assistive technology as well for the other people who has different disabilities, so that we are now working with them in order to increase this one, not only from wheelchair, to expand it that they can receive the right assistive technology that can fit their needs. And this is what we are working now as occupational therapy with the Ministry of Social Affairs.
Thank you for your question. Any other questions or feedback? Yes, please.
My question is for Dr. Hamid Shahab. Can spasticity be managed with occupational therapy alone, or is it often a combination of treatment with another?
Sorry, could you repeat it? I did not catch that first part.
It's okay. Can spasticity be managed alone, or is it often a combination of treatment?
Yeah, I'm sorry I did not mention it because it goes beyond the scope of the presentation, but there is a combination of things, medications, injections, all sorts of things, plus the manual therapies such as occupational therapy, physical therapy, and all sorts of other therapies.
I mean, with other majors?
With?
With other majors, like PTs and...
Yes, physical therapy is a huge part of it, and it depends on where the spasticity is. Even speech and language therapists and pathologists could work on patients who have spastic, for example, muscles that control their speech, if they're spastic. Yeah.
Thank you so much.
So at the end, I thank the presenters again, Dr. Mohammed Shihab, Ms. Bishara Kamri, Dr. Hamid Al-Hamid, and I thank you all, the audience now, for your questions and attendance. And again, I wish you all the best. Thank you.
Mr. Mohammed from Mr. Mohammed from
Today our guest is Dr. or the first guest of our session today is Dr. for his public health. He was as a professor at the University of Minnesota 2015-2020. I still remember Dr. Mohammed Al-Khalid during the pandemic of COVID-19. Probably and the statistics that was excellent, which was reflected in international recognized journals.
Thank you. Introduction. Application in terms of artificial intelligence. You know, we the system that have these programs to inject some sort of concepts in terms of what does AI is composed of. It's machine learning, okay? And machine learning now it is the new field of statistics. It's going to be replaced. So what I'm going to be showing you machine learning in terms of advancing health, as it's important as an academic when I use an AI-based system, it's important that I understand the component of this AI system. And I'm sorry to say because I'm an epidemiologist and I have obsessive compulsive syndrome, or, you know. The advantage, even the inherent biases in the data itself. So the idea here, find a lot of resistance, okay? Machine learning handle the biasness of health science. So let me tell you one example. Phenomena is biased. Important concept in epidemiology, we say that the health phenomena clustered in machine learning. This is where we introduce the idea of machine learning. Machine learning is about statistical learning. Basically, it handles big data, understands relationship, and we have two major components of machine learning. If we have a kind of no disease, no classification issue, if we have the outcome is distributed. Okay, so we have machine learning. The position of machine learning within artificial intelligence, basically it's the brain of artificial intelligence. And we can use this brain actually to handle the data that we have, even if we have examples. So the most important part of that ML is a subset of AI. And basically, how do we start machine learning? Available data, and then we have statistical methods, and then we have computing power. So one of the parts that in order for us also to start these activities, we have to start appreciating buying, computers with high capacity in terms of computing, and that's basically also a very important component in that sense. So machine learning has 3 types. Involved image recognition, speech recognition, natural. And basically here we label the data. We have the defined outcome, and we have multiple variables, and we see whether these predictors are important in the risk of that outcome. We have big data, and I am unable to define what is an outcome and what would be a analyzing this kind of outcome. So I explore relationships between give me the correct. So that's basically in summary how machine learning works. There are multiple algorithms that we explore. So basically we don't run one model, we run multiple. Which model performs better? So basically, when you want to buy an AI-based system, you need to ask the guy who sells you the system, what is the sensitivity, what is the specificity, what is the accuracy? These are important metrics within the machine learning that compose the AI system itself. So these are the visual steps that that we can do in that term. AI versus diagnose. With these things. So machine learning models, the amazing thing about it is that does not require the p-values and confidence interval have unrealistic or not. Then it is widely used. Why? Because it's easier for the clinician to interpret. Okay, and that's one of the things that we need to. And then also we need to also machine learning is insensitive to effect size. So with the traditional statistical, if you have size, you don't have significant p-value. But then when you have a larger sample size, you have significant p-value. So sometimes you have p-values for significant in terms of predicting your outcome. Now, we have published many papers on available data so far, predicting outcomes for. And let me just show you what can we get out of machine learning. So basically, we run multiple models: random forest, gradient boosting, support vector machine, and then we assess their specificity, and feature importance. What are the most important features in predicting an outcome? So that's these kind of metrics. And the nice thing is that machine learning is all about. Now, one important assumption reflect epidemiological plausibility. Health phenomena is complex. So predictors of my outcome, they have interrelationship. They are not, and there are non-linear relationships. So if the relationship between the outcome and the showing, and that's in terms of machine learning, analyzing the data. Also, machine learning for interactions, multiple interaction in the higher dimensional space. So, not just or the which are very important to analysis of or have you heard about after we build all of these models, at the end did not develop the outcome or the IQ. We define feature importance, relationship between the predictors and my outcome, and interactions between the predictors of my outcome. And this is basically how the health phenomena is done. Now, one thing, this is very complicated. There are statistical packages that are accessible. Even my student now is working with the simple form of these models for their capstone project using secondary data, and we have plenty of data. One of the most important tools doing machine learning models developed in Kuwait. People who sell based systems, they train their AI based on data from the US or from actual genetics or population of my country. So the necessity of developing machine learning model based on Kuwaiti data is very critical because the model will predict my outcome based on Kuwaiti population, based on the genetic population. And that's very critical part of why, even as an academic, we need to initiate these kind of models. Types important outcome here in the clinical decision. Machine learning is a very important risk stratification tool for the clinician. Regardless, the basic fee, other developed based on a statistical method, but then the population itself is biased because it's based on American population or European population. So basically, or this risk stratification, they don't use accurate prognosis or diagnosis in that. Okay, so examples, I know because of time, if you have any questions, we can talk about them later, but I would like to say, the flexibility of machine learning, also in the expansion of okay, and that's one of the things also we are doing with my students, use spatial data, GIS. So we integrate machine learning models in GIS, which is a very important component in terms of studying. Identify important factors for the spread of infectious disease on continental level. The important thing with studying infectious diseases with their complexity. If diseases are not complicated, they would die out. But because the disease is so complicated and the epidemiology is so complicated, only machine learning can predict or use, the complexity of these kinds of things. And predictor for the spread of. So if you even have a disease that has multiple serotypes or strains of variants, machine learning could distinguish between the variants. And that's the power of machine learning as well. Again, One of the things that we have to understand is that as an academic, we need to integrate, and I did an experiment with my student. It was very successful. They were very receptive. Academics is to push for this to be in the curriculum. And we need, as Kuwait University, to be advancing in that method. There is a lot to talk about, but again, there is a lot of variety. If you have any question, we can talk about it later, but this is basically why start to recognize and work with that kind of, especially for decision making. So now we work to improve decision making and prognosis and diagnosis.
Our next guest, our next speaker is Bahrani from MLS Department, Faculty of Allied Health Science, Kuwait University. Genetically modified bacteriophage for the selective delivery of therapeutic genes in brain cancer. Student and one of the first students who rejoined the department after getting her PhD. I would like you all to welcome Dr. Mariam Al-Bahrani to give us about prostate cancer.
Today I will be more specifically for targeting gender. Okay, so first, okay, they have different applications. Phage therapy in the clinic. They are used for identification and food safety. So basically, they can be added to water. They can be sprayed on crops and meats and poultry, and approved. For today, I will be talking about cancer therapy and gene delivery system. So bacteriophage in cancer therapy. So the bacteriophage, like genetically modified to target such as melanoma, sarcoma, so how this bacteriophage hybrid was constructed. So basically we combined two viruses, the M13 bacteriophage. The genome of the bacteria repeats from the adeno-associated virus. And then the therapeutic gene was incorporated within the mammalian cells. Because it's bacteria virus, so it doesn't have the mechanism to express the genes within mammalian cells. And also to ensure targeting, as you can see here, the red, maybe in the mouse. Okay, yes. Anyways, the red bits, internalization of the virus within the sequence that can target certain receptors on cancer cells. And the sequence that we used is called RG. bind to on cancer cells. Now this model, the AAVP, which is in A, was further modified. Smaller bacteriophage, and this was yield of the production was way higher than the older version, and also it has a smaller genome, so we can incorporate a bigger DNA sequence. So in case if we want one gene, easier and feasible. Okay, so I think on this version we call it TPA, which is transmorphic. This model to target medulloblastoma pediatric. We tested this in vitro using medulloblastoma cell lines, and then in vivo using mice models. So basically for the we checked the internalization, the gene expression, the cell, and then we combined it with cisplatin, which is a chemo drug that is commonly used for medulloblastoma. So on the top here, I'm showing the mechanism. Within the cell and deliver the therapeutic gene. So why medulloblastoma? Medulloblastoma is the most common pediatric long-time side effect. And that's from the surgery, so the treatment is the surgical resection of the chemotherapeutic drugs. As in our study, we used with the gene therapy. So why TNF-alpha gene? So previously, in previous studies for melanoma, chondrosarcoma, and for bacteriophage for the delivery of TNF-alpha, and it showed promising and nice results. Also, the efficient for the treatment of a tumor-bearing pet dog. Natural tumors on pet dogs. And also TNF-alpha as sarcoma and hepatic tumors. So as I mentioned, the phage was targeted by the integrin sequence. So would bind specifically to certain receptors. And the first step, we wanted to see blastoma cells, whether they express those receptors in order to ensure the binding and the internalization of the virus. And as you can see, the alpha V, beta 3, and beta 5 were highly expressed in both cell lines, the DOI and UW228. Then we looked at the anti-tumor effect. So when I say RGD in the blue, this is the targeted vector carrying the therapeutic gene. The non-targeted also expression within these. We looked at the expression at the mRNA level and the cytokine expression. So both cells that were transduced with the targeted vector showed high expression of TNF that the gene was delivered. And then it was graphs. Okay, then we tried the combination therapy. So as you can see here, we have the mock sequence, the therapeutic sequence, so the scrambled sequence. So in the first row, you can see the 5 micromolar cisplatin, CDDP means cisplatin, and then in the combination therapy, here the cell killing, augmented. So in the graph, the blue side showed TNF-alpha, and the red is the mock. And as you can see, when we combined cisplatin with the TNF-alpha, which is the therapeutic gene, then we looked at the expression of TNF-alpha when we the cisplatin with the therapeutic gene, and when we saw that there is higher expression of the therapeutic gene, meaning that it actually did activate of therapeutic gene. Like the chemo drug, it didn't only act on its death, but also of the therapeutic gene. Experiment in vivo. So basically, that with medulloblastoma. The tumor was allowed to grow. First with virus, and then after 2 the cisplatin and the bacteriophage. Now, interestingly, the bacteriophage intravenously, which is usually directly to the tumor. But here we wanted to see the injected intravenously. So as you can see, at day 14, the first batch was the treatment with the vector alone, and then the second, the vector and cisplatin. So day 14, the RGD4C, the targeted vector, when it was like injected to the mice, at day 14, we with cisplatin. So in the graph here, it shows a summary of the results. The green is day 14, the blue is, the green is day 4, blue is day 14. The vector alone did show significant decrease in the tumor size, and then the combination therapy showed enhanced effect. The other graph is showing that the mice were growing fine, so even at the end of the experiment, so this is the biodistribution. So after injecting, was there any non-significant? So as you can see here, we have different organs, the lung. We saw that only expressed in mice that were injected with the targeted vector. Now, here, the tumor sections and screening for the vector, and CD31 is the marker for the blood vessels. So the tumor that was injected with the RGD4C, as you can see, we did see that the vector itself, and there was a nice co-localization of the vector and the tumor vasculature here. It turned into yellow. And also the vector was within the tumor as well. We were not able to see targeted vector alone. So we're not expecting to see this. Now when we marker for the blood vessels, the tumors from the mice that were treated with the RGD4C showed significant reduction in the blood vessels, meaning that targeted the tumor cells. أقرأ؟ Okay. So meaning that the vector did not only induce its effect on the tumor itself, but also on the tumor vasculature. So basically, when you cut the blood supply to the tumor, this is more advantageous. Okay, so this is to detect apoptosis. Cisplatin is known to induce apoptotic cell death, and so we noticed that the combination therapy, with the green bits, so these are apoptotic cells. It's of apoptosis. So the combination therapy showed significant increase in apoptotic cell death. Showed high specificity and gene therapy for melanoma and injected intravenously. It showed nice also targeting. This study shows the potential of this therapy against medulloblastoma. So acknowledgement, this research was funded by Kuwait University, Children's Cancer, and was done with a That's it.
Thank you so much. Please, can you share with us the seats here?
صح. طلع ما منه فايدة. يقولون ما يسمعون.
Our last speaker will be Dr. Dalal Al-Maili. Dr. Dalal is from Kuwait University. Dr. Dalal earned her bachelor degree from Melbourne, Australia, and got her master degree from UK, and finally she got her PhD from the Trinity College in Ireland. Dr. Dalal is teaching immunology and immunohematology, and today she's going to give us a talk about immune profile, metastasis from colorectal cancer, future prospects with AI.
Everything has.
Please start.
Thank you so much, Professor Ali. I want to start by thanking the organizers for organizing such a nice conference for us today. I have a story for you, as all science capture your attention, and I want a little bit of history, a little bit of histology. Yes. So, our story starts in 1880. A staining method and became a standard diagnostic method in of what a human. So a few years later, a pathologist by the name of John Berg described immune markers on the or even so in 1974 and up to the 1980s, DAB which brown stain, table stain, became the gold standard for immunohistochemistry, and immunohistochemistry became a standard tool that pathologists use in order to diagnose different disease states. And that brings us to 2000, by a scientist location act as an work that I did during my PhD, showing you some immunohistochemistry in colorectal liver metastasis, and I'll tie all of this to AI at the end. So let's start with cancer. Cancer starts with a single abnormal cell. Now this single abnormal cell needs to be able to divide and grow into what's known as a tumor or a grow a blender, let's factors, throw in some mutations, let's throw in some environmental factors, some lifestyle factors, some drugs, and some infections, and all of this together will give me a nice mix of all of the factors that I need for cancer to grow and of protecting us, but it's actually very good at its job. And so it needs to be able to evade will bring me into the most important thing. Immune cells are smart. Tumor cells are not smart, but they are lucky. And let me explain what I mean here. Immune cells are smart. Within our bodies, we have a multitude of different subtypes of immune cells. Those immune cells have many different factors that recognize and get activated with an endless of pathways. They can recognize abnormal ligands. They can recognize the absence of normal stress signals, and they can recognize upregulation of proteins is supposed to be producing. Once all of this happens, the immune system gets activated, more cells get recruited, and all of them together, they produce a big number of proteins. Some of these proteins will activate the immune response even more. Other proteins will directly kill that are smart. On the other hand, tumor cells are lucky. The tumor cell that actually succeeds in growing the correct combination of mutations which allowed it to do three things: hide immune cells, inhibit the activity of the immune cells, and kill immune cells. How does it? These mutations will in the cell's ability to express proteins, and so it will not show those abnormal proteins. Other mutations, and those proteases proteins. Other mutations to fight the person up with a car that has a lot of power and is going at full speed. As we do this, at the in tissue liver, example, in tissue, hepatic cells, and then you'll have everything in brown. All of the this is within their have any. This was very for information. High recruiters and one known as low recruiters, also known as cold tumors, in line. We took that a step further. It did significantly correlate to survival. And thing that went right and to this point, we will talk about everything that I couldn't do beyond that point in my project. I became obsessed with answering the question, what is immune recruitment? Cold, hot tumors, then we are going to help patients about the tumor microenvironment and everything that affects it. We thought about cytokines and metabolites, different types of cells, of proteins. Able to see CXCL that we were not able to quantify data. Maybe Dr. Mohammed will prove me wrong later. Other than that, of looking down a microscope, other things. Add that invasive margin. So I also witnessed points accumulate at the point. Gateway. Data that I a step further. Few short years after. Quantified in the past. Image analysis within medicine. Quantitative and my talk. Pictures that
Before anyone starts asking the question, I would like to introduce. How can AI سلاح can we implement? We are also our teaching will improve our analysis, will improve. That aid in this and improving it.
Because this is the future to in regard to whether it's the academic
already using it. There, at least know how it could.
Yes, we already now started, as you see, we have published papers, important component of AI. Now, first of all, we can do workshops for the faculty, in terms of, understanding the basic form of and implementation, then analysis, basic elements of AI and machine learning for students. Like I've showed you, there are many ways of, introducing this to them and how we integrate this. A lot of things will make sense because what I've showed you can be linked to biological and disease reality. just so enjoyable. Let's say you have a register. Variety of these variables. We also can use the pixels. So, you know, what I've showed, that's actually based on clinical variables. And one data. So we downloaded climatic variables, population variables. We're able to predict different, you know, outcome, and we was disease like a Pluton. Okay, so what I'm saying here.
AI, image analysis, so that's to histology, to cytology, to that's going to revolutionize everything. The other big drive worldwide, personalized medicine. One of the biggest in research in general is that there is a huge variation. Beautiful. Okay. All of these results and take into account multiple factors simultaneously. It will allow the best possible outcome for everyone, specifically on their results.
We have new sciences, health sciences that deal with these kinds of things. So what I'm trying to say is that chronic diseases like cancer and heart disease and all this has not. Why? If the relationship between the outcome does not a strong way. Yes, will equate. We will then still I think احنا ك AI وحتى between the old
to be honest. Definitely, I will. The beginning, it was the start. Yeah.
these varieties of different outcomes and هذا unfortunately now
أول شيء في صورة جماعية مع ال organizing committee. Please step up. دكتور محمد, can you join us?
So we have an impressive list of speakers for our last session, starting with Dr. Maram Fatih. Dr. Maram is an assistant professor at the Department of Hearing and Speech Science at the Faculty of Allied Health Sciences. She received her Bachelor of Science degree from Queen's University and attended graduate school at the University of Queensland, Australia, where she received her master's degree in clinical training in communication disorders. Dr. Khadi received her PhD from Sydney University, Australia, specializing in the assessment and treatment of stuttering in children using the COMA program. Dr. Khadi has taught and supervised communication disorder students in clinical placements at Queen's University. Her areas of interest include disfluency disorders, voice disorders, neurogenic speech-language disorders, and dysphagia. Currently, Dr. Khadi works at Sabah Hospital, ENT department, assessing and treating adults with voice and swallowing disorders. Dr. Khadi is a certified speech-language pathologist by Speech Pathology Australia. Thank you, Dr.
Thank you. Thank you for the introduction. Thanks for making it to the final leg of the conference. I really appreciate everybody being here. I'll try to make this a nice, light presentation. Today I'm going to be talking about advances in imaging technology. I'm going to tie the theme of the conference with something speech-related. So although it's not going to be data that I've published, it's going to be a topic that's near and dear to my heart. So it's looking at diagnosing dysphagia with video fluoroscopy. Okay, so just a brief outline. I'm going to be talking a little bit about dysphagia for those of you who don't know what dysphagia is, so bear with me. And then I'm going to give a nice overview of video fluoroscopy, the procedure itself, post-assessment protocols that we use as speech therapists, And then I'm just going to touch on a little bit AI. It's quite an extensive topic. It's new. It's an emerging field in speech therapy. So I'll do my best to just introduce that and how it's become a game changer. So dysphagia is a swallowing disorder that impacts the movement of the food anywhere from the oral cavity, the mouth, the lips, all the way down to the esophagus and the stomach. The prevalence is anywhere between 2 to 20%, depending on the publication, the paper that you pick up, but it's quite a range. The highest prevalence that we see is in the elderly population, where we find about 22% of adults over the age of 50. Of course, the numbers go up if you have neurogenic disorders happening as well. Health implications, so it does lead to lots of problems, things like malnutrition, aspiration pneumonia, which can cause a lot of morbidity and even mortality, dehydration, and of course the reduced quality of life. So the causes of dysphagia are vast. It could be, our patients are anywhere from, people with neurological conditions such as stroke, post-TVAs, TBI, neuromuscular diseases like ALS, Parkinson's, CP. We also see some patients that have structural anomalies, so things like tumors, esophageal strictures, diverticulum, which is like a pocket that develops within the esophagus, even scarring after surgery or after radiation. And then we have the few, or the smaller group of individuals that have swallowing difficulties because of aging. So we go through that sometimes, and some individuals develop dysphagia because of just the changes that happen due to aging. Some medications do cause side effects, and dysphagia can be one of them. And of course, things like pharyngitis, oral thrush, which is a fungal infection, that can cause dysphagia, and GERD, so gastroesophageal reflux disease, any kind of reflux, that also leads to voice and dysphagia, voice problems and dysphagia as well. Just a quick question, how many stages of swallowing do you think we have? Just throw a number at me. 2, 4, 5. Okay, so it's actually 4. Sometimes they group them into 3. They are 4 stages. If you look at this diagram, it shows you the movement of the bolus. Bolus meaning food or liquid that we ingest, okay, the green portion. So the movement of the bolus in the oral prep phase, that's the first phase, that's preparing the actual bolus, the food, and then it gets pushed back, so that will be the oral transport, so that's the oral phase. We then have the pharyngeal phase, where it's in the actual pharynx, and then in the esophageal phase. So the movement really dictates where it is, at the stage of swallowing. Now, the goal of accurate assessment and early diagnosis is very, very crucial, as with many things in speech therapy. It prevents further complications for the patients and mortality in a lot of the cases that have, like aspiration pneumonia. It helps us develop effective treatment plans. It reduces the length of hospital stay, which is really important for the patients and their families, and it improves their quality of life overall. The dream team that we work in is, of course, SLPs, OT, PT, dietitians, physicians, respiratory therapists. It's extensive. We can't live without the nurses and the radiologists, so they are also part of the team. It is within the scope of our practice. Okay, and a lot of the general public, but as well as a lot of health professionals don't really understand or know that, the assessment of dysphagia, especially with imaging, is within the scope of our practice. So this is something that we are able to do and we are trained to do. So the main association, the American Speech and Hearing Association, defines the scope of our practice as SLPs, which includes the assessment and treatment of swallowing disorders, specifically noting the use of instrumental evaluation. So video fluoroscopy with radiologists is within the scope of our practice. So we are qualified as SLPs to be in the radiology suite. Typically what we do is we begin with screening the patients. So that would involve, it could involve us, but it can also involve trained nurses who know how to pick up on dysphagia, the signs and the clinical signs and the symptoms. It's a simple bedside test. We use a checklist. It could be a number of tests, checklists that we use. Things like the water swallow test, the Toronto bedside swallowing screening test. There's lots of them out there, but that takes minutes. And we look for the obvious signs of choking, coughing, and wet voice. That usually indicates red flag, something is happening with the swallowing process. If we suspect or see anything, we move on to a deeper kind of or more in-depth analysis, and we do a clinical assessment, and that usually involves digging into the patient history, looking at the medical history, doing an oromotor exam, which is part of a bedside assessment. So the oromotor exam is assessing the nerves and the muscles within the oral area and the face. We can't trial some swallows, which means we give them some food, some liquids, just to see and observe what's happening. And of course, nutrition and hydration status is also on our mind. So we're always looking at that and seeing, is the patient getting sufficient nutrition and hydration? And then silent aspiration would be in the back of our minds, of course, but that's something that we don't always see. We can pick up on different, using different things, but we have to keep that in mind. So silent aspiration is when the food or the liquid goes through the airway, but there's no obvious clinical signs like the choking, coughing, or the wet voice. Okay, so it can get missed. If we have sufficient evidence, great, but if we don't, a lot of the times we move on to the gold standard, which is using instrumental assessment, and that would be video fluoroscopy or FEAS, which is the flexible endoscopic evaluation of swallowing. I do the FEAS in Jabir Hospital, and we will begin to do the video fluoroscopy soon as well. What's the difference between them, you might ask? Okay, pros and cons for each one. Video fluoroscopy basically gives you a nice AP view, lateral view, and you can see all of the stages of the swallowing that I talked about, the 4 stages. You can look at the oral phase, the pharyngeal phase, the esophageal phase, etc. It does have radiation exposure, okay? It's not portable, so I can't do a video fluoroscopy in the inpatient or outpatient. I can't move around the video fluoroscopy device, so I have to take them to the radiology suite. Aspiration detection clearly detects aspiration during swallowing, penetration. It can tell us if there's residue, so anything left in the alimentary canal. And so it's a comprehensive swallowing assessment. The FEAS gives us a good, quick look at, everything super, primarily within the pharyngeal region. Okay, so the video fluoroscopy is a dynamic radiographic study that evaluates swallowing mechanics, uses fluoroscopy. Its advantage is it's detailed in terms of visualization of the oral, pharyngeal, and esophageal phases, like I said, but the limitation is radiation exposure. I'll talk more about the other limitations. The procedure is very quick. We have the patient, as you see here, seated in the upright position. That's the speech therapist there feeding the patient different consistencies, so thin liquids, pureed, honey, consistencies of food and liquids. And that's usually coated with barium sulfate, which is a radio-opaque substance. It helps visualize movement of the food and the bolus through the 4 stages. So we work throughout the consistencies, starting typically with the thin liquids, and we move on until we see, okay, there's red flags, then we stop. We stop at the consistency that we think they are aspirating on. So it's a 5 to 10 minute procedure. It gives us a good assessment of the function and the integrity of the swallowing process, bolus transit, meaning that movement of the food, and the liquid throughout in the 4 stages. This is what a video fluoroscopy looks like. You can see some of the anatomical landmarks. So here you have the epiglottis up there, the hyoid bone. It takes a lot of training and skill to kind of identify marks and to see their proper movement and function, and to understand, you know, that this is actually working properly or not. So that's a lateral view, that's an AP view, and with the you can see a bit of pocketing at the pharyngeal level. So the FEAST does not give us that. It doesn't give us all of that detail. The things that key indicators that we're looking for are things like aspiration, so that movement of the food or the liquid into the airway. Penetration is movement of the food or the liquid, but up to the level of the vocal cords, and then it gets expectorated or pushed out because they have a cough. And then residue is what you see here in the valleculae and the piriform sinuses in the pharynx. That's pooling and pocketing of food or liquid. And that is actually dangerous because the patient can eventually aspirate that. That can go into the airway. And another thing is the delayed swallow reflex. You know, if the swallowing reflex is too slow and delayed, then that's an issue as well. So this is what a normal swallow would look like versus what an abnormal swallow would look like. So this is the trachea. The food is moving into the esophagus. It's nice, brisk, it's fast, clean. Here we see that the bolus is moving slowly, but then it goes into two different parts. It goes into the esophagus and then into the airway. So that's aspiration, a lot of aspiration. Key features, so real-time imaging is a nice thing about video fluoroscopy. It allows us to look at the swallowing process in real time. It gives us frame-by-frame analysis. So we look at the kinetics, the pathophysiology of the process itself. And it uses radio contrast agents. Post-analysis, or post-assessment, I should say, we use different protocols, okay? We have different protocols. So we review and analyze the recordings, frame by frame. It takes us a very long time. We have interdisciplinary collaboration, so we collaborate with the radiologists, and then nutrition, and then nursing. We document what we see and find in these videos with detail, because that really determines what the treatment plan is going to be. And we also educate and teach the patient and their caregivers about what's happening, what's safe for them to eat, what's not safe, positioning as well, and it helps with monitoring progress. Lots of different post-assessment analysis protocols are also out there for us. The one that I use is the one I highlighted here, the modified barium swallow impairment. However, with video fluoroscopy analysis, using these tools, it's quite time-consuming. As you can see here with the modified barium swallow impairment profile, there are 17 components. It takes me a very long time to go through this for each patient. And I have to look at every phase and every stage of swallowing and say, yes, they passed, no, they didn't, you know, etc. And there's a scale as well, so it's not really just yes and no. So it's time-consuming, and it's also prone to human error. So this is where AI has come in. It's become a game changer. It's a new thing in the field. And they've used AI in lots of things like analyzing speech samples, natural language processing, teletherapy, and for the purpose of this talk, I'm going to be focusing on dysphagia assessment. Lots of different models are also out there. I'm not very well-versed in these, but there are many options out there, as I know. Convolutional neural networks, CNNs, deep learning, recurrent neural networks, lots of different approaches, depending on what you are looking for. So AI can analyze the video fluoroscopy images, basically. You feed it the information. It takes in all the data of lots of studies, video fluoroscopy, and it kind of gives us, or it helps in the diagnosis process. So it identifies abnormalities with much higher accuracy. So it takes the scans, the databases, okay, and it kind of gives us aspiration risks. It looks at delayed swallows, if there's any anatomical abnormalities. It is consistent, it's time-saving, and cost-effective as well. Lots of studies are now out there talking about this, and I think this should be the new way for speech therapists who are interested in swallowing disorders, is to maybe shift and look at AI. So there are lots of studies, basically, and the findings I've highlighted here show that they are helpful in early identification, effective in detecting the swallowing impairment, they enhance assessment accuracy, they reduce clinician variability, and they help with the decision-making process. Okay, AI identifies the subtle impairments that sometimes we don't even pick up on. And so they found that this is quite useful for us in early detection, even when things are not very clinically apparent with some patients. They've also found that it's reduced human subjectivity and error. And it helps with personalized treatment plans as well. Dr. Dalali touched on that, AI and tailoring treatment for patients. So this will help as well. So it gives us immediate feedback. And the nice thing also is eventually it can be used in telehealth to help underserved areas as well. Nothing comes without challenges. So as many of my speakers before me noted, challenges and recommendations for AI is a must, is something we need to keep in mind, and we must keep in mind also that we use it with caution. So training data needs to be of high quality. Clinicians should not accept the AI interpretation without critique. Clinicians should consider individual differences as well, as my colleagues have also noted. And exposure to ionizing radiation is an important consideration when we do the data collection as well. And clinicians should be able to interpret and explain these findings, not just completely rely on AI. Okay, Professor Muwafaq is not here, but I quoted him today. He said, curation of good data, strong and accurate data is essential, when we're using AI. That trains the algorithms to give us good, accurate results. So we do go with caution. Okay, AI will not replace doctors. It will replace those who don't use it. I truly believe so. That's all from me for today. Thank you.
Thank you, Dr. Please come have a seat next to me. Save your questions for Dr. Maal to the end of the session, please. And for our next speaker, Dr. Samawi is an assistant professor at the Department of Hearing and Speech Sciences. Please welcome to the stage. Dr. Samawi joins Pratt University for the Speech, Language, and Hearing Sciences Department at the George Washington University, where she was an assistant professor and served as the associate director of clinical research. Dr. Samawi received her PhD from the University of Toronto, Temerity Faculty of Medicine, with collaborative specialization in neuroscience. As a licensed clinical speech language pathologist in Ontario, Dr. Samawi has practiced studies and with a varied patient population across the university health network and hospital systems. She's an American board certified specialist in swallowing and swallowing disorders and has worked in the field as a clinician, clinical supervisor, and practice-based researcher. Dr. Samawi's research work to date has explored the relationship between thyroid kinematics, tongue pressure, and swallow safety, both in a healthy cohort and in patients with dysphagia.
To speak to you all today about a topic that's very near and dear to my heart, which is dysphagia assessment using video fluoroscopy. I'll say that we have no financial disclosures to disclose, me and my team members. For my talk today, I'll begin by discussing background, then move on to discuss dysphagia measurement and some of my work. Wonderful collaborators from the University of Toronto in Canada, Dr. Katrina Seal, Heel Swallowing Rehab Research Lab, who assisted in conducting much of this research. So Dr. Maram gave a lovely introduction to swallowing and swallowing disorders, and I'll touch on it briefly as well. Healthy swallowing actually involves a sequenced contraction of more than 26 movement across our oral, laryngeal, and pharyngeal muscles. And this contraction reconfigures our passive breathing tube into a mechanism of transport. So it directs the food and liquids into the upper esophagus, while at the same time away from the entry of that. Swallowing is actually modulated or semi-controlled by supramedullary and cortical structures, those that are above the level of the brain. Descending inputs to the central pathway to provide control of both respiration and swallowing. However, when these mechanisms are impaired, say due to some neurological related issue, this is where we have something called dysphagia, where individuals become at risk of food being left behind after the swallow, termed as residue, or material going down the wrong way, entering the trachea, potentially down to the lungs, as either the level in which it has reached. Dysphagia places an affected individual at risk for a series of negative health sequelae, including malnutrition, respiratory infections, dehydration. How do SLPs assess for dysphagia? Typically, this is conducted through a clinical swallowing evaluation or their fingers to palpate the hyoid and the larynx as the patient takes a bite of food or a sip of liquid. However, given that we have learned as a field that this exam is not, would hope, in all patient populations, we actually move towards conducting gold standard assessments, including the video fluoroscopy and the FEES swallowing evaluation of the swallow musculature. Very similar to what I showed earlier, but this slide illustrates what we conduct as part of our gold standard assessment, and you can see some of the structures that we look at labeled in the image. As SLPs, we're actually more interested in how these structures are moving, the physiology of the structures, and the dynamic movement as someone is swallowing or taking down that material. And that we can see in the video that's playing on the slide. In this video specifically, we see dark material entering the airway, making its way to the lungs, which means that this is an unsafe swallow. And not only is obtaining the image important, but actually the analysis and the interpretation of the image affect our understanding of the disease and prognosis for our patients. So despite this exam being our standard, how we measure muscle movement and function actually matters. In a study by Stockley and colleagues, they found that video fluoroscopy exams rated by 9 independent, experienced observers from international swallow centers actually had poor reliability. And this exam really suffers from that poor reliability between raters if there is no agreed upon protocol used. So we're highlighting the need for using a protocol in which people are trained to use in order to be able to reliably rate these exams. So, measurement from video fluoroscopy, our understanding of disease pathophysiology, and our practice patterns for treating these patients. So the question becomes, how can we measure a dynamic exam where we're taking 30 images per second in a reliable and standardized manner? So the work I'm sharing today represents small pieces to train raters. The very detailed set of definitions in order to increase their reliability across a range of values for normal behavior and quantitative measures for these healthy adults. The goal here is to build a resource of expected values swallowing so that this will equip clinicians to be more confident in their analyses and in order to identify features of swallowing in their patients that are different from healthy normals in order to identify mechanisms of impairments and targets for intervention. Our first study was a study in 2019 where we published the first article introducing the method of video fluoroscopy or video fluoroscopy rating, and we shared means and standard deviations for the resulting parameters. During this study, we actually had a balanced sample of 38 adults under the age of 60 with no symptoms of aphasia or other related conditions. So using the aspect method, we analyzed both swallowing timing events and swallowing pixel-based measurements using normalized swallowing events. This is a really busy slide, but this is a histogram of the full aspect analysis method, which incorporates all of the parameters that have been identified to actually be relevant for swallowing in our literature. On the left side, you'll see the full video recording is actually spliced, anonymized, and rated. Each clip gets rated by the raters, where they identify the number of swallows, whether penetration, aspiration has occurred, and then they move on to all the purple. Those we identify variables, and they become the measurements in which we rooms for very long hours and debate identify the correct frame before we reach agreement in order to resolve these issues, and then we have pixel-based hand measurements of these parameters. So completing the full analysis protocol actually yields a comprehensive summary of the swallow, whether any impairment exists, and provides us with metrics of overall swallowing safety and efficiency. Those are then the boundaries of the healthy reference intervals in order to determine whether any atypical patterns exist, in the same way that we would for lab values from a blood test. This image actually shows one of the structures that's been identified as a subject of much research in our swallowing world, and that's the hyoid bone. The hyoid bone is a horseshoe-shaped bone, but what's interesting about this bone is that it's a floating structure attached to the rest of the head and neck via muscles, several of which play a key role in swallowing. And the arrow really shows us the path that it takes during the swallow, so it moves up and forward, away from the path of the bolus. So it pulls the laryngeal vestibule out of that pathway to create a biomechanical traction that facilitates its closure. Ultimately, it's widely accepted that dysfunction in the movement of the hyoid bone would explain any unsafe swallowing behavior. I'm actually going to speak about this portion of the aspect method in detail, so I want to emphasize that we collect both position along the X, the Y, and the XY, along with the speed of the hyoid bone when we use the aspect method. Part of the work looking at video fluoroscopic measurements across the range of swallowing was done during my PhD, and this is where we provided values for a sex-based sample or a sex-balanced sample of healthy adults under the age of 60. And the data set included 27 swallows or boluses for each of our participants. This was quite cumbersome in terms of participant swallowing. And we actually had them swallow both xanthan gum-based thickeners and those boluses thickened using a starch-based thickener in order to determine whether there are any effects for the thickener type that's used that would impact swallow-based parameters. And then we rated all of these swallows using the full aspect method. And included within that aspect method was the hyoid parameter analyses, where we tracked the position of that hyoid bone frame by frame, starting 5 frames before it started moving until 5 frames after it rested. So as you can imagine, this was quite cumbersome for the raters as well, but this allowed us to use anatomically normalized measurements for each individual and to be able to normalize and compare across individuals and compare across the different norms that we were hoping to provide. And based on that, we were able to publish reference peak hyoid position measured along the XY hypotenuse from the C4 vertebrae. And you can see here that we found relatively little variation across consistencies and textures used between 168 to 170% of the C24 scalar. And this finding is actually quite important because it emphasizes that healthy individuals are very consistent in how they swallow. So regardless of the texture and regardless of the thickener that we use, we know that this should be the range of hyoid bone movements. So on measurements and only to compare against the thresholds that we provided, so clinicians can be confident in using those numbers. Now, recall that I mentioned that clinical evaluations of swallowing involve which we consider a subjective measure of movement of the hyoid bone based on that digital or finger to judge whether the movement is reduced. The other more objective method of measurement is the one I mentioned of the hyoid bone, where we're tracking the frame-by-frame movement, and the video is playing here to show you on every frame we place markers to track the movement. The question is, are both of these measurement methods of and the literature tells us that the answer is no, they are not. So while perceptual methods may contribute to our clinical decision-making process, clinicians should really be cautious when they're interpreting their subjective measurements from digital palpation, as these are not as accurate as using a pixel-based or timing measurement for hyoid bone movement. The next study I'll talk about was the results of our team actually questioning the value that measurement of the hyoid takes. I mentioned earlier that this takes hours and hours of the clinical rater time. So is this process actually something we need to incorporate in our measurements, or is it really something secondary that we don't need to be looking at or considering? In this study, we recruited a large sample of patients who actually were considered for at-risk neurological oropharyngeal dysphagia. And we defined this as non-congenital, non-surgical, and non-oncological related dysphagia. So anyone who qualified based on a neurological diagnosis was recruited into our study. And we had 305 participants who underwent video fluoroscopies with 6 sips of thin liquid each. We used the aspect method to rate their video fluoroscopic swallows for the different parameters. Then we graded whether these values were typical or atypical using the raw scores that we obtained and compared them against healthy reference values, as I mentioned in the other studies. Our analysis started by looking at each parameter and its association with impaired penetration or aspiration, so unsafe swallowing. And here we found that incomplete laryngeal vestibule closure and prolonged time to laryngeal vestibule closure were strongly associated with penetration aspiration, while reduced anterior movement of the hyoid bone and reduced speed of the hyoid bone showed weaker relationships. And then we also found no significant relationships for superior peak anterior hyoid position with penetration aspiration. We took this a step further and built 2 hierarchical logistic regression models in order to understand which atypical values were most explanatory for penetration aspiration. And our first model included the entire data set, excluding the duration parameter. And in this model, the strongest associations were only incomplete laryngeal vestibule closure and time to most complete laryngeal vestibule closure. Our hyoid parameters were not significant. The second model looked at the subset of data with complete vestibule closure and included duration of that closure. And here again, the strongest associations with penetration aspiration were prolonged time to most complete vestibule closure and a short vestibule closure duration, not any hyoid parameters. So as you can see, regardless of the regression model we built or we fitted, we found no significance for our hyoid parameters when it came to the odds in leading to an unsafe swallow. In summary, I think this gives us a better picture of what the hyoid bone contributes. Clinicians need to be cautious as to how we measure hyoid bone movement and whether it's actually going to be related to a patient not swallowing in a safe manner. And we need to be accurate and valid in making these measurements. Now, if you still want to make these measurements, then we really suggest that you measure using a tracking methodology from a video fluoroscopy and you don't rely on that digital finger palpation. We also emphasize a shift in understanding of unsafe swallowing and really focusing or honing in only on the laryngeal vestibule parameters, as they're much stronger predictors for unsafe swallowing as opposed to the hyoid bone parameters. I'd like to end this talk by talking or thinking of the future. How can we shift away from the manual frame-by-frame analyses conducted by a clinician and automate some of this work so that it's done very quickly and very accurately? And this is a recent, or fairly recent study that we conducted by looking at the use of convolutional neural networks in a data set of around 1,245 bolus clips from 59 healthy subjects. Here we proposed a deep learning framework that jointly tackled both pharyngeal phase detection and bolus localizations using these convolutional neural networks. And after conducting extensive experiments using these CNNs, we were successful in actually training an algorithm to identify the start and stop of the pharyngeal phase. So once we validate this in a larger sample of participants, we think our framework will pave the path for the development of more intelligent tools for video fluoroscopy analysis to support clinical assessment in swallowing. So this work highlights the importance of imaging when it comes to measurement science. Therefore, access to technology for speech-language pathologists is a very critical piece in our work with patients with dysphagia. And collaborative care alongside the different practitioners, including radiologists, radiation technologists, computer scientists, engineers, and many, many more physicians, is imperative to helping our patients who do present with dysphagia. And with that, I thank you for your attention and look forward to the discussion in the question and answer session.
Thank you, Dr. Sharifa, and thank you all for being here for the very last presentation, which is on videotoscopy and asynchronous diagnosis of middle ear disease, specifically related to middle ear infections, which is known as otitis media, or OM. Sorry. Can you hear me now? Okay, cool. So middle ear infections, which are also known as otitis media, is a term that refers to a spectrum of middle ear inflammations, including acute otitis media, which is typically characterized by or has a rapid onset of symptoms, including ear pain or otalgia or fever. We also have otitis media with effusion, which is another type of otitis media that's typically asymptomatic and has a or is characterized by presence of effusion in the middle ear cavity. And as you can see in the otoscopic image showing effusion or fluid, and you can see the bubbles there indicating effusion behind the eardrum or the tympanic membrane in the middle ear cavity. The accumulation of middle ear effusion during or after episodes of otitis media can decrease the mobility of the tympanic membrane or the eardrum and the small bones in the middle ear, and can consequently limit the middle ear's function in transmitting sound signals from the outer to the inner ear. Therefore, middle ear effusion is regarded as the main cause of hearing loss, and hearing loss is regarded as the most common complication of otitis media. The OM-related hearing loss tends to be of a fluctuant, transient, and conductive nature, with an average of 10 to 35 decibel hearing loss across the speech frequency range. Therefore, otitis media can interfere with adequate and inconsistent auditory input to the auditory central nervous system, and may therefore interfere with adequate speech perception and language development. Otitis media is considered as one of the most common childhood diseases with a peak prevalence occurring in the first 2 years of life. And the immaturity of the immune system and the eustachian tube, which both have an important function in the protection against otitis media, contribute to the high prevalence of otitis media in the early years. And we know that this period is critical for language and other aspects of development. Although spontaneous recovery can occur within 3 months, it has, or OM has a high rate of recurrence, meaning that some children may retain their fusion for, including the subsequent hearing loss for extended periods, and can adversely affect their development in different areas, including speech, language, as well as academic performance. Untreated persistent OM can also progress to significant and serious medical complications, including extracranial complications, such as tympanic membrane or eardrum perforations, and also intracranial complications, such as meningitis. Unfortunately, children are often burdened by limited access to care, and this can increase risks for these complications to develop. In the past years, telehealth has emerged as a promising solution to this worldwide issue, and the term telehealth means the provision of healthcare over a distance using technology. And for children with otitis media, the use of such technology as videotoscopy can enable the ENT specialist to remotely assess the appearance of the tympanic membrane, and this part, or assessing the tympanic membrane, is essential for making a diagnosis of otitis media. Videotoscopy is a procedure that involves the use of an otoscope with a built-in camera to capture still images and recordings. And several studies have utilized videotoscopy images or recordings and found that it helped in improving access to ear health services. And the procedure is clinically appropriate, effective, and is safe. However, to the date of this study, the images and or still images and video recordings have not been compared directly against each other, and it was still unknown which one can improve the ability to assess the tympanic membrane and make a diagnosis of middle ear disease. Therefore, we conducted our real-life research study, which we call the Ear Explorers, because children were able to explore what's inside their ear, which is quite fun. This study was held in at two public community events in Perth, Western Australia, back in October 2019. The main aims of the study were to compare the clarity of video otoscopy still images to recordings, identify the variables that can affect the clarity of video otoscopy still images and recordings, as well as comparing their suitability for making an asynchronous diagnosis of middle ear disease. Only children who aged 6 months and 15 years who had informed consent provided by their caregiver and had no contraindication for testing, including recent ear discharge or experiencing or ear surgery 6 weeks prior to the study were included. After providing consent, caregivers completed a questionnaire which was used to collect relevant case history information and to confirm children's eligibility for the study. After that, video otoscopy was conducted by a group of testers, including ENT specialists, audiologists, and research assistants. And we had both non-clinician and clinician research assistants like nurses. So the equipment we used was HearScope, which is the equipment at the top, and you can see the otoscope attachment connected to a smartphone which managed the display and the capture of the images and recordings. So we collected still images and recordings bilaterally, so that's from both ears. Titan middle ear analyzer was then used to conduct tympanometry, which is an objective test of the middle ear health. And that was conducted by either audiologists or research assistants, also bilaterally. A few weeks later, the results were reviewed by 2 independent reviewers, an ENT surgeon and an audiologist. The review process comprised 2 parts. The first one was an evaluation of the clarity of the still images and recordings, and this part was done at ear level using findings from individual ears which were presented randomly. The reviewers were also unaware whether the still images and recordings were related to the same child. The reviewers were asked to make an evaluation of 5 different domains, including quality, focus, light, sediment amount or earwax amount, field of view, and lastly, they were asked to make an overall rating. The second part was to make a diagnosis at child level using findings from both ears. Initially, the reviewers were asked if they were able to make a diagnosis, and if so, to make a diagnosis by selecting one of 3 different categories. Normal, abnormal, clinically insignificant, meaning that the child does not need to be referred for further investigation and treatment. And finally, abnormal, clinically significant, meaning that a referral is needed. Now results, we managed to collect 280 image recording pairs from 150 children with a mean age of 7 years, and the majority were female participants. We also identified 18% of children with some middle ear abnormalities. Now, comparison between the clarity, in the clarity between still images and recordings. I will quickly show a comparison between the ratings of both procedures as described in percentages. So we have recordings in blue and still images in gray. And as you can see, there were more recordings rated as excellent and good compared with still images for the quality domain. And we also found same results here for focus. So we have more recordings rated as either good or excellent compared with still images, and the opposite for the for still images, we had more still images rated as adequate, poor, or very poor compared with video recordings. Same results were obtained from the light domain. And in terms of sediment amount or earwax amount, there were less differences between the still images and recordings. And it actually makes sense because obtaining different views of the same ear at the same time point would show fairly similar amount of wax and would obscure the view of the tympanic membrane to the same degree, regardless of the otoscopic procedure used. Then there were more recordings rated as 100% compared to still images in terms of field of view, so how well the clinicians were able to identify or to see all the key structure needed for making a diagnosis, and again more excellent and good overall ratings favoring recordings over still images. We then conducted a pair sample t-test and found that the difference in mean between still images and recordings was statistically significant in the overall rating, as well as the quality, focus, and the field of view, and also in the domain of light by the ENT surgeon, and a trend towards significance for the audiologist. Sorry. We found no significant differences in the ratings of the sediment amount by either clinician, and this table only shows findings from the right ear pairs, as findings from the left ear pairs were consistent with these findings. Then we conducted a hierarchical logistic regression, and that's to identify the factors or the variables that can affect the clarity of the images. And we found that across all the domains, age of the participant has a significant impact on the ratings. And we found an improvement in the ratings with each 1 year increase in age. We also found that videotoscopy procedure has a significant impact on the ratings of quality, focus, field of view, and also in the overall rating, with recordings increasing the likelihood for better ratings. The role of the reviewer was only significant in the sediment amount, as appeared in the ear canal, with the audiologist reporting more sediment amounts than the ENT surgeon. The ear side and the role of the person obtaining still images and recordings had no significant impact on any of the rated domains. And regarding the suitability for making a diagnosis, we found that the recordings increased the ability of or the ability to make a diagnosis compared to when still images were used, and this difference was significant for the ENT surgeon and also for the audiologist, who reported more ability to make a diagnosis using recordings compared with still images. Now, this was the first study that directly compared between videotoscopy still images and recordings in terms of the quality and their suitability for making an asynchronous diagnosis by clinicians. And our findings suggest that video recordings can improve improve visualization of the tympanic membrane and the ear canal, and also increase the capability to make a diagnosis and may therefore improve the quality and the reliability of the current telehealth services. We also found that age has a significant impact on the clarity of both still images and recordings, and we know that challenges such as reduced compliance or cooperation during tested may have contributed to these findings, and also the characteristics of the ear canal of younger children. So this highlights the importance of incorporating findings from objective tests along with the videotoscopy findings to reduce risks for inability to make a diagnosis, and therefore the need for re-examination causing further delays. We also found that research assistants, including nurses, were able to or were as capable as audiologists and ENT specialists in obtaining videotoscopy, still images, and video recordings. And this actually highlights the role of nurses in improving access to services via telehealth when face-to-face examination by a specialist is not readily available. And like with any study, there were limitations found in this study. The sample of children participating in this study might not be representative of other children. Remember, this study was conducted at 2 public community events, which is usually an attraction for children and families who are overall healthy. So the sample may not be representative of other children with recent ear discharge or surgery, or those attending ENT and emergency departments who are unlikely to attend these events. We also, another limitation was the absence of a reference standard, which limited our ability to assess the accuracy, the specificity, and sensitivity of the videotoscopy still images compared to recordings. We published 2 papers out of this project, and you can find all the details and further analysis, including tests, retests, reliability of both procedures, which I wasn't. And finally, acknowledgements. This research was supported by a scholarship from Kuwait University and was funded by the Kids Research Institute and the Government of Western Australia Department of Health. I would also like to thank all the volunteers who helped with data collection from the Perth Children's Hospital and the Kids Research Institute. And of course, all the amazing families and children who agreed to take part in this study. Thank you.
Thank you, Ms. Fairmount. Have a seat. Let's open the floor for questions. Any questions for our experts? Go ahead.
Thanks for your excellent presentation, mashallah. I like, and I enjoy listening to your presentation, especially when you talk about your PhD, you're passionate about your study, years of work, and showing the result to us. I have a question for Dr. Iman. You mentioned that your result about pediatric population. Do you think if you did the same study with geriatric, it will be different, and how it will be different?
That's a good question. I know many studies that investigate the application of videotoscopy with older populations, and I think so. Do you mean like that video
video recordings would be more preferred over still images? Yeah, I think so, because relying on one image, one still image, would increase risks or inability to make the diagnosis. While if you have a video, then you have a chance to see different image frames, they call them. So that's, I think that will actually improve the ability to make the diagnosis. So my simple answer is yes, I think so, but we need to do research, of course.
I have a few questions for Dr. Maram and Dr. Sana. Thanks for your talk. Back to your talk about the study you did and the imaging procedures that you are using to diagnose the speech disorders. I can realize that the study done on only an upper part of the esophagus. And is there any study from esophagus down?
You did? So the swallowing process, typically, speech therapists were involved from the oral cavity all the way down through the pharynx to the esophagus. Then it's gastroenterology field. So what we are involved in is typically, that first section of the allergy canal. So the oral cavity, the pharynx, the esophagus in the beginning.
I can see it's about the where the
yeah.
little higher bone and C-spine only, and not the
Yeah,
the head.
all of that. So that would be then gastro.
I'll just jump in and add, Dr. Maran talked about SLP's screening. So one of the things we can do is screen for esophageal dysphagia. So sometimes we do have the fluoroscope or the fluoroscopy go down all the way through the esophagus and watch the bullets as it flows, but we never do diagnosis of the esophageal canal. That's really gastroenterology and their scope. So we can obtain the images and then we'll forward them to the gastroenterologist and they'll read and interpret the esophagus. That's kind of like a heart surgeon looking at the brain, different areas for different expertise.
Okay, but you are exposing the patient to two different days of procedures, right?
Exactly, which is why when we do the screening, we'll actually take those images and send them to the gastroenterologist. They don't have to do another video fluoroscopy. They obtain our images, use them to interpret what's happening in the esophagus without having to expose the patient again.
They can also be with us during the study, so they can also be giving input as well. Where we do the speech part, and then they.
Yeah, I want to understand the protocol.
Yeah. Yeah, of course we reduce as much as we can radiation exposure.
Thank you. Thank you so much. I'm pleased to be here because you are graduating from the place that I graduated from Australia. And I like the accent, the Australian accent that you are, because you are coming fresh. Thank you so much.
Do you have any more questions?
Thank you very much for your wonderful presentations. My question is fairly generic, maybe more relevant to Dr. Maram and Dr. Sana. From my clinical experience, at least, with neurological conditions, stroke, post-stroke patients, they tend to complain quite a lot about getting choking. The frequency of it happens, even though there is no real hardcore evidence of anything abnormal, but they complain about it. Is that something that they need to be checked out, and what are the signs that someone might look for before they could seek out professional review?
So when you're saying a stroke patient, that immediately tells me neurological damage somewhere. And if they are complaining of food getting stuck, global sensation, regurgitation, or then this is something that we assess instrumentally. If we can't say anything clinically, like with the bedside, it's the steps that I showed you. So we do a screening first, and then if we notice any choking, then we move on, and then we do usually the instrumental exam is what really gives us the information, and then you can visualize and see.
Because they said they used to have the same thing, but the
frequency of the choking?
Yes.
Okay, there's a lot of factors there. I mean, I have to look into, do they have gastroesophageal reflux? Are they on medications? And then I would have to do also video fluoroscopy as well.
So seek a specialist.
I'd also say if something is actually getting worse, I would be worried about the stroke actually developing into something larger in the brain. So that's one of the things that we see in patients where it starts as a small stroke, they have minimal symptoms, and then they start complaining more and more. And when that happens, there could have been watershed, or the stroke could have evolved into something else, a hemorrhagic transformation. So we work very closely with our neurologists to get in there really early and diagnose it using imaging and see what's going on.
Do you have any more questions? I'd like to ask a question actually. So I'm just wondering, in Kuwait, where's videography done and also videography done? So you mentioned Jabir Hospital. Yeah.
So right now we do it at Jabir Hospital, and I believe they do it also in another hospital. But the thing is, because we need speech therapists to be there, ones that are there all the time doing these regularly are the ones in Jabir Hospital. Other hospitals, they have SLPs that come in once a week, once in a while, from TMR to do it. I think they do it in any week. But it's not very well established, like there's no really well-established system in all of the hospitals. You'll find that maybe in one or two hospitals being done.
To answer your question, I'll also say collaborative care is really important. And so radiologists, a lot of the time, are the ones leading these exams. And so having a seat at the table, working with them, having them call us when a patient's coming in for a dysphagia swallow study is really imperative for us to actually get these patients seen and have them access. And so Dr. Mahan and I are actually working on a pathway for some of these patients.
In terms of videography, I'm not sure. I don't think it's currently utilized in hospital here, but potentially we can utilize videography in the future. As I mentioned, it's clinically appropriate, doesn't require substantial training, it's safe, effective, and also a few studies have utilized videography in telehealth services in different settings. So I think that can be done here in Kuwait, but of course that would require a well-established IT infrastructure for telehealth, and also we will need to have an economic assessment to investigate its cost effectiveness, and then hopefully we can utilize this equipment in the future.
I'd like to thank our experts. Thank you so much for your insight and enlightening lectures, and thank our audience for your attention. Thank you very much. We would like to
يعطيكم العافية جميعا. Thank you very much. دكتورة إلهام، دكتورة ليلى. دكتورة شريفة القيري. دكتورة شريفة. دكتورة شريفة. دكتورة شريفة حياك. دكتورة مرام الخالدي. دكتورة سناء سماوي. دكتورة إيمان العنزي. طبعا واخيرا وليس اخرا احنا دكتوره ليلى كانت امس مودريتر فتستاهل التكريم. ترى تستاهل بعد صفقه. نختم ان شاء الله مع الدكتوره ليلى رئيسة اللجنه العلميه Head of the Scientific Committee. تفضلي دكتوره.
السلام عليكم. I would like to thank each and every one of you for your participation. Dr. Mohammed Nadar, thank you very much for your support and for believing in us, and you are such a motivator. This way, of course, distinguished speakers, thank you very much for sharing with us the updates in your field. Exhibitors and the sponsors, whom without their support, this event wouldn't have happened. And dear students and audience, thank you very much for your attendance and sparing your time to be here and listen to the talks. They need above all, the organizing committee, I have witnessed hard-working and teamwork at the same time. Without it, really this wouldn't be a success in this event. Thank you very much, all of you, including طبعاً the scientific committee. اوكي، وما ننسى اللي يعني ما وراء الكواليس. الإدارة عندنا ما قصرت. وطلال والمجموعة كلها رايتكم بيضة، والإعلام طبعاً ما قصر، ويعني الصور شغالة واللقاءات. تسلمين إلهام أنت والكرو مالتك، يعني thank you very much. وأتمنى نقلب شوية عربي وإنجليزي. طبعاً كل الستاف, my all colleagues, you know, those who are even behind the scene working, حتى لو هم مو organizing or scientific committee, all my colleagues. وأتمنى أن we have really learned many lessons from the talks, and we can take home messages, and mainly in these 2 days about implementation of AI in classes, in the postgraduate level, in undergraduate level, and try to adapt ourselves to implement these high technologies and also AI in our career and fields. وأتمنى أن this is not the last event, أن في events to come, and I hope to see you in the future, near future. Thank you very much, وأتمنى لكم weekend سعيد. شكراً.